So good morning all of you.
Good morning, sir.
Is it audible?
Yes, sir.
So Suresh sir, as I said, when I was joining for MBBS, I did house runs in SAS unit. So even from that time I know him. That house runs I did as of 1999. So from that, so almost 25 years of teaching, guidance and friendship. So I consider it a privilege for sir to invite me here. I consider it as an honor by invitation by Suresh sir. So we will discuss today the stroke topic. So as you know, stroke is often kept for exam as long case. All 75%, if 100 candidates are coming for exam, 75 of them will get stroke as a long case. And remaining 25 will get, lucky persons will get cirrhosis liver. Some persons may get respiratory case. So majority will get stroke patient. So candidates are expected to know everything about how to arrive at a diagnosis, how to present a case. You would say whether it's a cortical lesion, stroke and even the person who brings the taxi person will tell it is stroke. Medical student is supposed to tell it is whether it's a hemiparesis, hemiplegia, it's an internal cap solution, cortical lesion, or if there is a quarter of the cranial nerves affected, or is it a brainstem lesion, and what is a blood supply, which artery territory is affected, and what is a vascular supply, what are risk factors. So, you have to tell in final diagnosis. So, how to present it in a systematic manner and how to exactly present a diagnosis. So, if you get a stroke in examination, where how can you exactly tell whether it is which is a site of lesion, which is a blood vessel affected, which are the anatomical structures affected. So, we will have a systematic discussion of the such cases. So, we will start with some basic aspects of stroke. If I straight away jump into localization, you will be confused. So before going into localization, I will just review about the anatomy, blood supply of the brain, what are the areas supplied by different blood. Then only you can do. If I say anterocirculatory stroke means, first you have to know what is anterocirculatory and areas supplied by. So we'll start with the anatomy, types of stroke, and then come to localization. And then we will discuss the how to present that case. So what is stroke? You should know. The cerebrovascular accident is considered as the second leading cause of death in the world. Sometimes there is no infarct and it recovers completely in less than 24 hours. Then it is called a transient. So many persons can develop. We have seen patients coming with mild right hemiparesis. Then they say by evening it completely disappeared and CT will be normal. Such cases you call transient ischemic attack. And 85% of strokes are considered ischemic, 15% is hemorrhagic. So when you present a diagnosis of stroke, you are also supposed to whether it is a ischemic stroke or hemorrhagic stroke. 100% you cannot say because sometimes hemorrhagic stroke may not have symptoms. Otherwise, that is why you need a CT scan. Otherwise, if you are 100% your clinician can tell means there is no need for radiology. So the majority of strokes are ischemic, 15% is hemorrhagic. Importance of that is in hemorrhagic stroke, you should not give drugs like aspirin. Thrombolysis is contraindicated. If you thrombolize a patient with hemorrhagic stroke means they will die. We have to take a CT scan and look for hemorrhage. But even without CT, is it possible for a clinician to tell whether there is hemorrhage or ischemic? Yes. Because if there is hemorrhage, usually there can be raised intraocular pressure. So there will be headache, vomiting, projectile vomiting, seizures can be there. So these are all clues. But is it necessary that all cases have all these symptoms? Sometimes small hemorrhage can be asymptomatic. Hemorrhage cause symptoms only if it raises the intraocular pressure. If it's a small hemorrhage and the intraocular pressure is normal means there need not be symptom. That is why you take a CT scan. Otherwise, no need for CT. Clinician can tell it. So the types based on the circulation, as you know, there is a circle of Willis. Number 2 is cerebellum, and number 3 is occipital lobe. Pinna thalamus. So you can note down. Four anatomical structures. If you are saying that the site of lesion is in the brainstem, cerebellum, thalamus, or occipital lobe. These are the areas supplied by posterior circulation. So you have to say, first you have to say site of lesion. If I am saying site of lesion as thalamus, or occipital lobe, or cerebellum, then that means it is a posterior circulatory stroke. Then 20% of strokes are lacunar infarct. What do you mean by lacunar infarct? Lacunar infarct means all major arteries have perforators. Perforators are very small branches of major arteries. But these perforators are very small. They are only micrometer in diameter. So the infarct will be also very small. When you get a small blood vessel, means infarct is also small. So those infarcts which are less than 1.5 centimeter in size are called lacunar infarct. So can you tell which are the arteries with the perforators? MCA perforators are called Charcot's artery. They supply the internal capsule. Then PCA has perforators that supply the thalamus. Then basilar artery has perforators that supply the pons. So there are lacunar infarct syndromes. So these are the classic lacunar infarct syndromes. Why it is called pure motor hemiplegia? Pure motor hemiplegia means normally in hemiplegia we can get aphasia, loss of cortical sensations, you can get gaze palsy. Here there is nothing, only hemiplegia. So it's a pure hemiplegia. And where is a sighted lesion? Posterior limb, because the corticospinal tract passed through the posterior limb of the internal capsule. So when there is a lesion of the posterior limb of the internal capsule, you can get pure motor hemiplegia. Which is a perforator? What is a perforator supplying the internal capsule? It is called Charcot's artery, or the artery of that is also the artery of cerebral hemorrhage, artery most vulnerable hemorrhage. So both hemorrhage as well as infarct can occur in that artery. Both can result in that pure motor hemiplegia. And what is pure sensory stroke? Which is a sensory relay station in the body? Thalamus. So what is the perforator supplying thalamus? PCA perforator supply the thalamus. So whenever I have seen a patient, when they say there is hemi-sensory loss, they say sudden onset numbness on one side of the body. Sometimes patient can get numbness only in the palm. That we say is carpal tunnel syndrome. If that patient has full body numbness from face to toe on one side of the body, it is likely to be a hemisensory stroke, and the CT will show a thalamic stroke, and that is also a lacunar infarct. What is ataxic hemiparesis? Ataxic hemiparesis, there is only minimal weakness. There may be grade 4 power, but severe ataxia, finger-nose incoordination will be defective. That is why you have to not only look for power, you have to look for coordination. Whenever you examine the motor system, you have to look for both power and coordination. Sometimes power will be grade 4, and you may think there is no stroke, but there will be severe incoordination. So severe incoordination with minimal weakness is called ataxic hemiparesis. Ataxic hemiparesis occurs when there is lesion of the cortico-pontocerebellar fibers. Normally hemiplegia, dense hemiplegia occurs when there is corticospinal tract lesion. In ataxic hemiparesis, it is cortico-pontocerebellar fibers, because some of the corticospinal tract fibers will rely in the pons and then they go to cerebellum. So that is how you get ataxia. പേര് തന്നെ ഉണ്ടല്ലേ, ഫൈബറിന്റെ പേര് തന്നെ cortico-pontocerebellar. Where is the site of lesion? Pons. And which is a perforator supplying the pons? Basilar artery perforator. So this another variant of ataxic hemiparesis is called dysarthria clumsy hand syndrome. There we get cerebellar type of dysarthria and ataxia. So these are all the lacunar infarct syndromes. Lacunar infarcts account for 20% of the strokes. And pathology is said to be lipohydrosis of small blood vessels. Risk factor is hypertension and diabetes. So now coming to blood supply. So before coming to the localization, first thing you have to know is blood supply. Somebody who is not aware of blood supply means we cannot teach localization. ABCD or English, like that. We have to first know the blood supply of the brain. So this is the മൂന്ന് കളറിലാണ്, purple, blue, green. Purple ഏതാണ്? Anterior cerebral artery. Blue one is the medial artery, and green is the posterior. So areas homunculus എങ്ങനെയിരിക്കും? How can you imagine how the homunculus, again physiology books like homunculus is set in such a way that the face and upper limb is ഏകദേശം ഇവിടെ ആയിട്ട് വരും അല്ലേ, പോയിന്റ് പോയിന്റ് അല്ലേ, ഇവിടെ വരുന്ന അത് ഇവിടെ വരൂല്ലേ അല്ലേ, കഴ്സർ ഇല്ല. That is not. So that blue area താഴെ is actually the face and upper limb area. അപ്പോൾ leg അവിടെ വരും, homunculus leg അവിടെ വരും. Leg comes in that purple area. Purple area is leg area. So which artery weakness cause isolated? So suppose stroke patient is coming to you with only leg weakness. I have seen patients. Once a patient came to me with leg weakness and he has urinary incontinence also. So the presenting complaint of the patient is weakness of one leg, and along with that there is urinary incontinence. Upper limb is relatively normal, good power. And what is that condition called? It is called crural monoparesis. If you get weakness of the one upper limb, it is called brachial monoparesis. Weakness of lower limb is called crural monoparesis. So this crural monoparesis means it is contralateral ACA tertiary infarct. And why there is bladder involvement? Anybody? There is a paracentral lobule that is also supplied by the anterior cerebral artery. And what about middle cerebral artery? Blue one. Middle cerebral artery actually supplies the face and upper limb. So if there is a cortical middle cerebral artery lesion, you get something called faciobrachial monoplasia, where there is weakness of the one upper limb and deviation of the angle of nose to that side. So let's say facial, that's called facial-brachial monoplegia. Leg is usually spire. There is a MCA weakness. And posterior subarachnoid supplies an occipital lobe. What will be the pattern of blindness? Is it unilateral blindness or something else? Suppose you get posterior subarachnoid stroke and the occipital lobe is affected by an infarct. What will be the clinical manifestation? Will you get complete blindness of one eye or another pattern? Some other pattern? You get a pattern called homonymous hemianopia. Homonymous hemianopia means half of the vision. When you see with one eye, there is a test called 10-finger test. It is called screening test. Some of you can come forward. One of you can come forward. That person, you can come forward. So I will show a simple test. You can stand face to examiner. You close your one place. Now I am also closing. Now can you see this? How many fingers are you seeing now? You look at my eyes only, don't look anywhere. How many fingers are you seeing now? 10. This is called 10-finger test. And 10-finger test, hemianopia patients say only 5. Imagine that you have left homonymous hemianopia. Then what will you see? You are a patient with left homonymous hemianopia. How many fingers you are seeing now? Only 5 is seeing, the other 5 is seeing. Now close this side. And now how many fingers you are seeing? Now imagine that you are left homonymous hemianopia. Now how much fingers? Again 5, which you are not seeing. That on the left. When you look with this side as well as with the other eye, with both the sides, the left side is not seen. That is called left homonymous hemianopia. That means it has a region of the either the right occipital lobe or the any other part. Suppose person has hemianopia. Where will you localize hemianopia? Is it only occipital lobe or anything else possible? Beyond the optic chiasma. What will happen if it is an optic nerve lesion? Nerve will cause complete blindness of one eye. Normally 10-finger test patient will say, I cannot see all the 10 fingers on one side, but he can see all the 10 on the other side. That means it is optic nerve. What is bitemporal hemianopia? Optic chiasma. Optic tract or beyond the tract and the occipital lobe, everything produces hemianopia. It is because of the crossing of the fibers. Because fibers cross like that. If you do anatomy books, this is where the visual fibers cross. Half from this retina, half from the other retina will go to the brain. So if one side brain is damaged, half of this side and half of this side is good. So this 10-finger test is a useful screening. I always check for 10-finger and stroke patients and see if there is hemorrhage. Many patients I have found out. Many patients when I do 10-finger test, they will say 5. So if the answer they give is 5 means they are instead of 10, if the patient is saying only 5 means. And what is a traditional method accepted in Hutchinson for undergraduate students to test for visual field? Confrontation method. You position your one finger on all the four sides. Examine 10-finger test may not be accepted. That is only a screening test. Traditional method MBBS student has to use for testing the visual field is a confrontation method. Confrontation method. This is more simpler technique. I said a simpler technique. So you know about blood supply to the brain. Now one question. Any other site can cause, we said optic tract can cause hemianopia, occipital lobe can cause hemianopia. One more site of lesion, stroke lesion has hemianopia. Anybody? In the which portion of the internal capsule? Not posterior limb, something more posterior. Retrolentiform part. Internal capsule is actually embedded within the lentiform nucleus. A portion of the internal capsule is behind the lentiform nucleus. That portion is called retrolentiform part of the internal capsule. And this retrolentiform part of the internal capsule carries visual fibers. So this visual fibers, we told it is coming from the optic tract and going to the brain. Which way it is going means through the retrolentiform. The optic tract is going along with the retrolentiform part and then only it is going to the brain. So whenever you get a lesion of the retrolentiform part of the internal capsule, you get the same hemianopia. So hemianopia has two differential diagnoses, either optic tract or the retrolentiform part of the internal capsule or the occipital cortex. Macular sparing and pupillary sparing. Two sparing occurs in cortical lesions. In cortical lesions, pupil is spared. Because pupil reflex is a local reflex. Pupil reflex doesn't require cortex. It requires only the optic tract. Before reaching the lateral genital body, pupillary fibers will deviate. So in somebody with hemianopia, you look for pupil. If the pupil response is normal means it is a cortical disease. That's called Wernicke's hemianopic pupil reaction. That means the hemianopic side pupil will normally react to light in cortical lesion and light reflex is absent in optic tract lesion. So this is the circle of Willis. Circle of Willis, how is it formed? That's the indian artery bifurcating into ACA and MCA, and the two ACAs are connected by anterior communicating artery. And the vertebrobasilar artery, what is that? At the top of the basilar artery it divides into two. What is that? PCA. Sometimes an embolus can come here. What is that syndrome called? That's called top of the basilar syndrome. Top of the basilar syndrome means embolus will come and sit on the top of the basilar artery. Can you imagine what will happen in that situation? Both PCA will be occluded, because when there is an embolus in the top of the basilar artery means both the PCA are occluded. So sudden onset of bilateral. I have seen one patient like that. What might be the symptom of that patient? Anybody can guess? There was once I saw a patient with top of the basilar syndrome, and what was the symptom he told? Sudden onset blindness, complete blindness. It is not hemianopia, complete blindness of both eyes. If a patient is blind, a patient will go to ophthalmologist or neurologist. Even if you are a doctor, if you get sudden blindness, will you go to neurologist or ophthalmologist? Ophthalmologist will say retina is normal, cornea is normal, lens is normal. They will take a CT scan, and CT showed bilateral occipital lobe infarct. They will refer to neurologist. That is how I got that patient. And this patient had bilateral thalamic infarct also. When I took the CT of that patient, it showed bilateral occipital and bilateral thalamic lesion. Why? How does thalamus come in between? Because the PCA has perforators, and this PCA perforator supply the thalamus. So top of the basilar syndrome means there is bilateral occipital lobe and bilateral thalamus. And patient will present with that phenomenon is called cortical blindness. That means blindness due to cortical reason. Most often such patients have another phenomenon called Andon syndrome. What is that Andon syndrome? Good. What you tell Andon? So you can stand up and tell.
Actually, they have blindness, but they will not accept the fact that.
Good. Very good. But you can give it to that. Andon syndrome means there is a denial of blindness. It is actually a part of neglect. The cortical lesions will neglect denial level. If a patient complains that actually patient is blind and he will fall down and he will bump into objects, but he will blame that there is not enough illumination or the sun is not too bright. He will say it is a cloudy day, because he will say some excuses. He will not accept that he is blind. That is called cortical blindness. So these are the risk factors for stroke that I just mentioned. This is actually not topic for today. You can just note down. So whenever a young patient with stroke comes, you have to look for this polyp. Recently I have seen a young patient with his hemoglobin was 18. I have seen a 25-year-old patient with stroke and his hemoglobin was 18. And he was a smoker also. It was smoker's polycythemia. So the polycythemia is a risk factor for stroke. Sometimes we get homocysteine, APLA syndrome. So all these things have to be rolled out in. And the most common cause for young stroke is cardioembolism. In elderly, it could be due to hypertension, diabetes. But when you present the final diagnosis of stroke, you are supposed to mention a risk factor. The examiner will ask you what is the risk factor for stroke in this case. But that also you have to search for. But elderly patient, you can say hypertension, diabetes, or peripheral. That is why you have to look for the peripheral pulse. Whenever you get a stroke patient in general examination, you examine the peripheral pulse. If the dorsalis pedis or posterior tibial artery is not palpable, you can say that this is a risk factor, atherosclerosis. Or he may be having diabetes. And in young patients, you have to make a thorough examination of the cardiovascular. Often people forget. In our MBBS, one gold medal candidate failed in MBBS. At that time, failure was common. Nowadays, failure means people go to court and do. In our times, even gold medal candidates used to fail. So when the marks came, one person was second rank in MBBS, but he failed in medicine practice. What was the reason for failure? See, he said cardiovascular system was normal in stroke patient, and patient had mitral stenosis with atrial fibrillation, and that was the reason for stroke. So you have to make a thorough examination of the cardiovascular system. So cardiovascular, because cardioembolism, AF, MS, or stroke. If you get a long case, you have to not only examine the neurology, you have to examine a quick examination of this cardiovascular system. Sometimes most of the stroke patients die due to pneumonia. Even recently I went to a court for a legal problem, and the cause of death in stroke patient was pneumonia. So that when judge asked how can you get pneumonia, what is it common, uncommon, they asked me for a witness opinion. So you are supposed to make an examination of the respiratory system, cardiovascular system also in a long case. When to suspect stroke? Do you think all hemiplegia in the world have stroke? I have said plenty of patients will come with hemiplegia means weakness of one limb only. Is it always stroke or do you get other causes also for hemiplegia? Any structural lesion on one side of the brain can result in hemiplegia. Brain any lesion there, it could be a tumor, it could be tuberculoma, it could be cryptomy, could be a fungal lesion, could be a glioma. So even it could be even demyelination, multiple sclerosis. So somebody asks you causes of hemiplegia means it is demyelination, multiple sclerosis, tumors, intracranial space occupation, glioma, everything can result in hemiplegia. So examiner will ask you why you tell stroke. You are telling that my patient is having CVA, left hemiplegia and it is a stroke case. Examiner will immediately ask you why you told stroke. Could it be demyelination? Could it be tumors? Could it be glioma? So what should be your answer? Number one is sudden onset. You say patient was normal till 9:45, 10 o'clock suddenly he developed. So you say tumor will not come like that. Then you say it obeys a vascular territory. What do you mean by obeying vascular territory? Obeying vascular territory means patient has a facial-brachial monoplasia, leg is spared. So it is likely to be a midicillary, or patient has only hemianopia. Suppose patient has hemianopia and aphasia. Then what is the problem? The speech area comes in midicillary territory, but vision comes in PCA. So if the patient has both aphasia and hemianopia means he has problem in both MCA territory and PCA. So it is two vascular territory. But you cannot say that two thrombus will come, one thrombus went to MCA, another thrombus go to P. That is a rare possibility. Then you think of diseases like demyelination. Multiple vascular territories only you have to think of disease like demyelination, metastasis, multiple space accumulation like that. Then risk factors. You can say that patient is diabetic, elderly. So you can say that my patient is a diabetic patient or he is having underlying cardiac problem and he is so I think there is a risk factor for stroke and he developed all of a sudden and it obeyed a vascular territory. His features can be explained by midicillary like that. Can you get a dense hemiplegia in midicillary? Because we said midicillary produces only facial-brachial. But I have seen lot of patients with midicillary having full dense hemiplegia. What is the reason for that? Midicillary also has perforatus called Charcot's artery, which we told. And this Charcot's artery supplies the internal capsule. So if you get a MCA stem occlusion, it can affect both cortex and internal capsule. Midicillary, you can say, if you trace the midicillary, there is a stem, cortical branch, perforator. If it is only perforator, we told lacunar infarct. If the perforators alone are affected, you get a phenomenon called pure motor hemiplegia. If the cortex is affected, you get facial-brachial monoplasia. If there is a stem of the MCA, main stem MCA, you get both dense hemiplegia as well as aphasia. Aphasia is due to cortical lesion. Dense hemiplegia is due to internal capsule. So MCA can produce all varieties of manifestations. So safest answer for an MBBS student is MCA. Stroke patient. Most likely your patient is having MCA. Because even if it is a pure motor hemiplegia, it is MCA. Even if it is aphasia, it is MCA. Even if it is facial-brachial monoplasia, it is MCA. Most likely you are going to get a MCA stroke. And MCA is also the commonest artery affected by embolus. They say aneurysms are more common in ACA territory and embolus is more common in MCA territory. So now coming to clinical approach. So localization, first you cannot do localization by magic. It is a step-by-step process. Listen, you are not a machine. CT scan, MRI scan, they use by the radiological measures for localization. Clinician, clinician, how will you arrive at your localization? You will take a careful history and examination. So first step is history. What all things you take in history? Mode and time of onset. Why it is important? Suppose the stroke occurred in early morning while you are sleeping, and it is then it is likely to be thrombotic. Suppose it occurs during activity, then it is likely to be embolic, severe. Then progression, which peak weakness. Suppose the weakness occurred at 9 a.m. and it peaked at 10 a.m. level. Within 1 or 2 hours it peaked. What type of stroke? Usually embolic stroke and hemorrhagic stroke. Whereas in thrombotic stroke, it gradually develops. Stroke, that's called stroke in evolution. Suppose patient has only upper limb weakness in morning, evening he develops lower limb weakness. So it is gradually developing. The stroke in evolution more favors thrombotic stroke. Sudden onset favors or peak development history, what was he doing? When a stroke patient comes, when you take history, ask him at exactly what point of time it occurred, how it progressed, when was the maximum weakness occurred. When the weakness occurred, it was more in the upper limb or lower limb, or when initially upper limb, then lower limb. So the natural history of the illness is important. You have to carefully analyze the mode of progression of the disease. Then you can say it is dense or non-dense. What is the relevance of that? Dense nuclei means upper limb and lower limb uniformly erect. Non-dense means one more than the other, which is furthering cortical lesion. Cortical lesion is not dense. Internal capsule and brainstem lesions are dense. So these are all points. When you are suspicious you have a doubt whether it is cortex or internal capsule. So all these points will help, whether it is dense lesion, non-dense lesion, proximal or distal. In general, UMN lesions have a distal tendency. What about raised density features? That favors a hemorrhagic lesion. Then is it weakness or imbalance? Suppose sometimes patients say they are swaying to one side while walking. Sometimes they say while lying in the bed I am able to move my upper limb and lower limb, but when trying to walk I have severe swaying to one side. Then there is what is more likely to be ataxia, because in cerebellar strokes and all it is more of ataxia than weakness. Then cranial symptoms. How the cranial symptoms help in localization? Because each cranial nucleus, all cranial nuclei are present in the brainstem. So suppose if the 3 and 4 cranials are affected, which portion? Midbrain. 5, 6, 7 means pons. 8, 9, 10, 11, 12 means medulla. So that is the importance. Cranial will exactly help in localization. If there is a suppose patient is saying I develop vertigo, vomiting, and when I try to swallow water it is coming through the nose. It is a common symptom. When our patient, when I tried to take a glass of water, when I was trying to swallow, it came back through the nose. That's called nasal regurgitation. That means this which cranial affected? 9 and 10. Immediately you say, immediately what structure you think, anatomical structure that comes in your mind is medulla. So localization. Now we are coming to a proper topic. That moment the patient says that there is nasal regurgitation, you will consider medulla. Or patient is say I got double vision. When I look to one side, there is a double vision. That means a double vision means it could be 3, 4 or 6. That means either midbrain or pons. And suppose if it is facial palsy. Facial palsy means deviation of angle of mouth to one side or in then you see whether it's a UMN facial palsy or LMN facial palsy. Other history, how can you understand? After examination you can understand history. What is a clue for UMN and LMN? Ask the person, is the eye closure normal? Suppose he is able to close his eyes and open normally, only the angle of mouth is deviation means it is likely to be UMN patient. If the full of the face affected, it is likely to be LMN patient. So what is the relevance of this LMN and UMN patient in a stroke patient? Stroke with LMN facial palsy means it is a condyle lesion. Because what is LMN? What is the textbook definition of lower motor neuron? Somebody can answer. LMN, lower motor neuron definition. One hour I will stand up and play. You can stand, play. Lower motor neuron. I will try as much as possible, then I will modify. Neurons from which level are called lower motor neurons?
Below the nucleus.
Neurons, the cranial nuclei in the brainstem and the anterior horns of spinal cord and nerves emerging from that. All cranial nuclei are considered LMN. Anterior horns of the spinal cord are also considered LMN. LMN means the cranial nuclei or the nerve is directly involved. Cranial nuclei is 17 nucleus. So LMN means it is either pons or the facial nerve. Whereas the facial nerve is under control from the brain. Brain is controlling your facial nerve through corticospinal tract. So neurons from the brain and their descending tracts till they reach the brainstem and spinal cord are called UMN. So in UMN, why the upper part is paired? Because the facial nerve has connections from both sides. Electricity is a 3-phase priority. Sometimes the neighbor's house will have electricity, your house current is gone. Why? Because neighbor may be having 3-phase and you are having single phase. So 3-phase means he will get multiple, even if one phase is gone, the other one is there. Whereas a single phase lesion means your full electricity. That is because this facial nucleus has connections from both sides. So even if there is one brain lesion, the opposite brain is connecting with facial nerve. That is why the upper part has bilateral connection. So if it is a brain lesion causing hemiplegia, facial nerve, this is a UMN facial palsy and it occurs in such a way that only the lower half on the opposite is affected. So if you get a left-sided brain lesion, you get a right facial palsy and the upper part is paired. Whereas if it is a facial nucleus that is affected, you get full of the facial nerve is affected. That is called LM and facial pulse. And nuclear lesion occurs on the side of lesion, whereas brain lesion occurs on the opposite. So if you get a left brain lesion, you get a right UM and facial pulse. Whereas what will happen if there is a right pontine lesion? Right pontine lesion goes right full LM and facial pulse. But where is hemiplegia occurring? Hemiplegia is going to occur on the opposite. In the other case, where was hemiplegia? In cortical lesion, hemiplegia was on the same side. Cortical lesion, you get facial pulse on the right side, hemiplegia also on the right side. So it is called ipsilateral hemiplegia. The other one is called crossed hemiplegia. Crossed hemiplegia means hemiplegia is going to occur on the left side, but facial pulse is occurring on the right side. So cranial nerves on one side and hemiplegia on the other side. Why? Because the cranial nucleus is not crossed, it is remaining there. Who is crossing? Corticospinal tract will go, is going to corticospinal tract on the pons will cross to the opposite. At the where is crossing occurring? There is a pyramidal decussation that occurs to the medulla. So even if you get a right pontine lesion, anatomical structures affected are the right corticospinal tract and right seventh nerve nucleus. Right seventh nerve nucleus is remaining there only, it is not crossing. But right corticospinal tract is going to cross to the left side at the end. So at the end of the day, you are going to get a left hemiplegia and right LM and facial pulse. Then you say the lesion is in the which pons? Right pons. So that is how this cranial nerve symptom. So you have to make a thorough analysis of which all cranial nerves are affected. Cranial nerves is one that important thing that helps in localization. Wherever in the brainstem, the hemiplegia is crossed. All brainstem syndromes are crossed. Whenever you get a brainstem lesion, you get cranial nerve lesion at the site of lesion and long tract signs on the opposite. This long tract can be either sensory or motor. In lateral syndrome, there is no hemiplegia, but you get hemisensory loss on the opposite. So there again, the sensory phenomenon occurs on one side and cranial nerve lesion occurs on this side. In all such scenarios, you consider brainstem lesions. Then speech. What is the importance of speech? Many stroke patients will have slurring of speech. They will say after the stroke my speech is abnormal, but that need not be aphasia. What is the other common abnormality in stroke? It could be dysarthria, because even if you get a facial palsy, there is a slurring of speech. Your speech, imagine that you have a facial palsy, can you speak fluently? There is a defective articulation of speech. That you look carefully whether it is dysarthria or aphasia. If there is aphasia, always you have to commit that which anatomical structure is affected. Cortex. So examiner will ask you where is the site of lesion. So you have to make a careful analysis of speech and see whether the patient has aphasia or dysarthria. If it is only dysarthria, that won't help in localization. Because dysarthria can occur in cerebellar lesion, chorea, all lesions can cause dysarthria. But if it is aphasia, it is very useful for the candidate. So if you are lucky, you are getting an aphasia patient. Because aphasia localizes the lesion to cortex. Which cortex? Dominant cortex. Because there is a Broca's area and Wernicke's area. Broca's area comes in frontal area, inferior frontal. Wernicke's area is superior temporal. Both are supplied by which artery? Whether it is Broca or Wernicke's, which artery? MC has a superior division, inferior division. Superior division supplies the Broca's area. Inferior division supplies the Wernicke's area. So if there is an embolus in the inferior division of the MCA, it will cause Wernicke's area. Superior division will cause Broca's. So what about stem of the MCA? That will cause global aphasia. So anyway, if you are getting an aphasia with hemiplegia means you are safe. You can say it's a cortical lesion and the MCA is affected. Then you won't fail at least. Because so if you get an aphasia with stroke patient means you can say it's a MCA lesion and cortex is affected. So first of all, you have to diagnose aphasia. For that, what you have to do? You have to look for components of speech. So when you examine the speech, 6 components of speech are there. Like fluency, naming, comprehension, reading, writing, repetition. This much things, which is a universal abnormality in all types of aphasia, whether it is Broca's, Wernicke's, in all types of aphasia, what is lost? Anomia. Anomia is a universal finding. Person, as you show the person an object. Ignorance object, patient much more simpler objects you have to see. You have to use a watch, or you have to use a spectacle, you have to use objects like. Many often, when I went to exam recently, naming candidate asked what is the name of the patient. Is it right or wrong? The candidate is asking the patient what is your name. Is it what you mean by naming? Naming means you should show an object. You have to ask the person what is this. What is this? Common 2 objects you have to show him and the patient has to tell the name of that object. Because this naming is a main language function. You have your own dictionary, like Oxford dictionary and all, we have our own dictionary in the brain. And so all the good words, bad words, are in your dictionary. So when there is a language problem or aphasia, when your broadcast area or vernacular is gone, your dictionary is not working properly. So when you get an object, suddenly you cannot recollect its name. That's called anomy. So when such a problem occurs in stroke, either there is a reduced fluency or reduced comprehension, anomia, then you consider cortical issue. Then systemic symptoms, review of system. You have to look for seizures. What is seizure suggest? Seizure also suggests itself more likely to be a cortical issue because neurons of the cortex, brainstem is unlikely to cause seizure. Internal capsule also unlikely. Seizure comes from the cortex, and more often seizure occurs in bleed than in infarct. Sometimes large infarcts can cause bleed, but usually a large infarct can result in seizure. Usually it is cortical bleed. Comorbid medical conditions, addictions, drug history, family history, even sexual history. HIV can also cause vasculitis. HIV can cause space occupying. I have seen hemiplegia patient with HIV, and his final diagnosis was toxoplasma. It was not stroke. We thought it was hemiplegia, admitted as hemiplegia. When MRI scan came, it was he had ring enhancing lesion in internal capsule, and this toxoplasma was compressing his internal capsule. So anything compressing the internal capsule can result in hemiplegia. So in that particular case, hemiplegia was due to toxoplasma. It was not stroke. That is why you need CT or MRI. Otherwise, there is no need for MRI. You can straight away do some medicine. We took MRI and all this to rule out other conditions. So examination, what all things candidates are likely to misplay. Why it is examiner, when examiner will ask you, have you checked for this, have you checked for this, then you say I forgot. If it is some minor things and all, they will excuse. Suppose you are saying I forgot blood pressure, I forgot plantar, I forgot knee jerk also, then they will be back from that side. So you have to, what are main things you look for means there's cardio. You have to make an examination of the cardiovascular system. You have to look for carotid bruit. Carotid bruit indicates risk factor for stroke. Peripheral pulses. Higher functions. Higher function you will see whether the patient is conscious. Which patient's strokes are likely to be unconscious. Which is a stroke syndrome where consciousness is affected. Brainstem stroke. Either it is large hemorrhage, very large hemorrhage with raised intracranial pressure can become unconscious, or brainstem can. Why brainstem strokes are drowsy? Because brainstem contains this ascending reticular system. So that is, and which stroke causes aphasia? Cortical. Aphasia is that for the prerequisite for diagnosing aphasia is patient should be conscious. In an unconscious patient, you cannot comment on speech. Suppose your patient is coma. Suppose somebody has a brainstem stroke and is comatose. Can you comment on his speech? Can you tell his aphasia? When you see the patient is unconscious, he is not even opening his eyes. Then you are asking him what is this, he is not telling. Will you tell it is aphasia? But then what should be the comment you should make? You should say patient is unconscious or comatose and I cannot test on speech. And this testing for speech is not possible. So the prerequisite for testing for speech means he should be conscious. Suppose patient is fully conscious, his eyes are open, he is maintaining eye-to-eye contact, and then you are asking you what is this, they is not answering, means you should say there is a possibility of aphasia. So only in conscious patient you test for speech. And speech tested only if conscious. This you can remember as a mnemonic, ABCD, cortical lesion. Okay, suppose the lesion is in cortex, what all things can happen? Number one is aphasia. Then anosognosia, which is dominant cortex, which is non-dominant cortex. Dominant cortex causes aphasia and non-dominant cortex causes anosognosia. So which hemiplegia patient is likely to have anosognosia, left hemiplegia or right hemiplegia? Right hemiplegia patients will develop aphasia. Left hemiplegia patient will develop anosognosia. Anosognosia, what is definition of anosognosia? Person is not aware of having a neurological problem. You know what is the example given in De Jong's textbook of neurology? One surgeon was doing surgery. Then at the end he came out of theatre and said that surgery is not possible because patient got hemiplegia. Then everybody rushed to the table and found that patient is not hemiplegia. Who got hemiplegia? A surgeon had hemiplegia. That is the example given in De Jong's textbook of neurology. Because he developed hemiplegia and he tried to lift the patients and it is not lifting. So he told patient is having hemiplegia. Actually it is a doctor who developed hemiplegia. That is called anosognosia. So anosognosia can occur when there is a left hemiparesis and they will be not aware of having a neurological problem. Bladder incontinence. Then cortical sensations. What are cortical sensations? Like stereognosis, tactile localization, tactile discrimination. So we have to do simple pain, touch and all may be normal, but specifically when you look for tactile localization, that specific cortical sensation is lost. Then you say it is likely to be a cortical lesion. And presence of convulsion also cortical lesion. Then dense lesion or not. Then presence of eye signs. What is gaze pulse? Where is the gaze center? Area 8 is called gaze. Brain is numbered areas. Area 3, 1, 2 sensory. Area 4 is motor, 6 is premotor. Like that, area 8 is called the frontal eye field. And this whenever artery territory, which artery comes then the area? That also middle. That is why I told whatever painting majority is middle cerebral artery. So this gaze palsy also occurs in middle cerebral. So aphasia, gaze palsy, facial-oblique monoplegia, everything can occur in middle cerebral artery lesion. So in gaze palsy, there is a area 8 frontal lobe that causes gaze to opposite. So when there is a left area 8 lesion, you get right gaze palsy. So hemiplegia also, everything happens on right. When there is a left frontal lobe lesion, you can get right hemiplegia, right UMN facial, right gaze palsy. Everything happens on right when there is a brain left lesion. And this gaze palsy also points that can you get gaze palsy in any other brain lesion? There are 2 gaze centers in brain. There is a PPR. What is PPR? Paramedian condyle. PPR is also, what is the difference between PPR of gaze palsy and frontal lobe gaze palsy? Left PPR of controls right, left brain controls right PPR. So 2 anatomy. If you want to look to the right gaze, what are the anatomical structures needed for right gaze? In order to produce the right gaze, you need right PPRF and left. They work coordinately. Left area 8 controls the right PPRF to produce right gaze. So somebody with the right gaze palsy means either it is a right PPRF problem or it is a left area 8 problem. So you have to see this gaze palsy. These are all points that help you in localization. So crossed dense hemiplegia. Where is the sighted lesion? Cross hemiplegia means you get hemiplegia on one side, but the cranial is on the other side. Then you always consider for underlying purpose, crossed means it is normally you get facial palsy on the same side of hemiplegia. Whenever you get a hemiplegia patient, you are expecting facial palsy and hemiplegia on the same side. Suppose if a cranial lesion comes on one side and hemiplegia is coming on the other side, you have to always diagnose should be a brainstem. Where in the brainstem depends on which cranium. If it is 3 and 4 on one side and hemiplegia on the other side, you say it is midbrain. If it is 6 and 7 on one side and 7 on hemiplegia on the other side, then it is called pons. So Weber syndrome, Millard-Gubler syndrome. Weber is 3 on one side and hemiplegia on the other side. Millard-Gubler is 6 and 7 on one side and hemiplegia on the other side. All these are at the end of the day coming under which category? Crossed hemiplegia. And in lateral medullary syndrome is also a crossed. Lateral medullary syndrome only difference is instead of hemiplegia there is semi-sensory. Because what is the reason for that? Because corticospinal tract lies in the medial medulla, whereas spinothalamic tract lies in the lateral medulla. So when there is a 9 and 10 palsy on one side, instead of hemiplegia occurring on the other side, you get pain and temperature loss on the opposite. Then you consider lateral medullary syndrome. And where you get cerebellar signs? Cerebellar signs occur on the same side. So hemiparesis, suppose you get hemiparesis grade 4 power with severe incoordination and finger nose incoordination. Then you consider ataxic hemiparesis. That may be due to a lacunar infarct in the pons. Homonymous hemianopia. What are the lesions possible? Either it is a contralateral occipital lobe or it could be due to retroleniform part of the internal capsule. Horner syndrome, ipsilateral cranial and contralateral sensory or motor. Why you get Horner syndrome in brainstem lesion? Because the descending sympathetic tract passed through. So the moment you see Horner syndrome, it could be a brainstem lesion. Spinal hemiplegia, Brown-Sequard syndrome. Anyone has idea? What will happen? Suppose there is hemisection of the cord. One half of the spinal cord is affected. In spinal cord, what is the problem? The corticospinal tract is already crossed. Why? You get hemiplegia on the opposite because if it is a lesion of the cortex, internal capsule or brainstem, when corticospinal tract is affected on one side, hemiplegia occurs on the opposite because the corticospinal tract is going to cross. Once you reach the spinal cord, crossing has already happened. So where you get hemiplegia? On the same side. If you get a right spinal cord lesion, you are going to get hemiplegia also on the right side. You are going to get sensory loss also on the right side. but only one event will be on the left
Maintain
side.
temperature.
Because spinothalamic tract has segmental level crossing. Dorsal column crosses only after reaching the medulla. Spinothalamic tract has segmental level crossing. So you get so suppose you get hemiplegia on one side, sensor loss on one side, but pain and temperature alone is lost on the other side, and cranial nerves are normal. All cranial nerves are normal. Then you consider Brown Sequard syndrome. Usual cause for Brown Sequard syndrome is bullet injuries. That is why we are not saying US like bullet penetrating injuries, bullet injuries, because spinal cord is a narrow structure. Diseases usually affect bilateral spinal cord, bullets and hemisection. So to summarize, hemiplegia can be due to cortex. Then you look for cortical signs. Cortical signs are aphasia, anosognosia, gaze palsy, cortical sensation, seizure. Then it will be always non-dense. When you get a dense hemiplegia, you consider Indian capsule. Classical Indian cap solution is called pure motor hemiplegia. It is called pure because there are no other signs. It is only hemiplegia, and it is dense. Crossed, you always consider brainstem. The Brown Sequard we have said. Attacks hemiplegia you consider Pons or lacunar infarct syndromes. So these are some of the slides. We can just go through the salient points. Anterior sublateral syndrome and some again. These are the salient points. So you need not by heart everything in this side. Say one. Remember only 1 or 2 points. Anterior sublateral syndrome. What is the main point? You get contralateral leg weakness with urinary incontinence. Middle sublateral syndrome. What can happen? You can get contralateral hemipulse with and facial palsy, and if there's a mediastinal cortex means you can get aphasia, you can get, and if it is a dominant hemisphere will cause aphasia. What will happen in non-dominant hemisphere? Non-dominant will cause neglect, anosognosia. Neglect, what is the symptom? Suppose patient say hemi-neglect means, have you seen patients, bystanders complaining that when he walks he will always hit on objects on one side? I have seen patients like that. Bystander will complain that he is having left hemiplegia, and when he is trying to walk he is hitting objects on the left side. Whoever comes on the left side. So if he is going to drive a car, what will happen? Somebody with left hemiplegia after is going to drive a car, what will happen? Right side is the lower element you can see, but left side will cycle. He will hit the cycle on the left, but he will escape the lower on the right. That is called neglect. Neglect is a DD of hemianopia. Hemianopia means it is a vision problem. Neglect can also is a condition which can happen. PCA lesion le hemianopia. MCA lesion can cause neglect resembling hemianopia. Now, neglect usually occurs when there is a non-dominant hemisphere, and aphasia occurs when there is dominant hemisphere. PCA we have told that. Then lateral syndrome, what are things ipsilateral? There is only one thing that is contralateral. Everything else is ipsilateral, lateral medullary. Contralateral is pain and temperature on the body because spinothalamic tract is crossed. All other tracts are uncrossed. What is medial medullary syndrome? Just like lateral medullary syndrome, there is a medial medullary syndrome. There are only 3 anatomical structures in medial medulla. Can you say 1, 2, 3? 3 anatomical structures in medial medulla. It is a corticospinal tract, anteriorly corticospinal tract, then medial lemniscus, and posteriorly there is a 12th nerve. You look for cranial nerve. The cranial nerve 9 and 10 is affected, it is lateral medulla. The cranial nerve 12 is affected, it is medial medulla. And if there is hemiplegia, it is medial medulla. It is hemisensor loss in medial medulla. Good. In medial medulla, it is anterior spinal artery. How many anterior spinal artery? How many posterior spinal artery? It is like auto. 1 anterior spinal and 2 posterior spinal. 3 wheel. 1 anterior spinal and 2 posterior spinal. And anterior spinal cause medial medullary syndrome, and lateral medullary syndrome is caused by an artery called pica. Pica are all branches of the which artery? Basilar artery. Pica is a branch of the vertebral artery. SCA and Ica are branches of the basilar artery. Ica cause something called lateral pontine syndrome, and pica cause lateral medullary syndrome. Whereas anterior spinal artery cause medial medullary syndrome. So now coming to name of the arteries and diseases cause. What will happen? Have you heard of ophthalmic artery? Ophthalmic artery is a separate branch of the internal artery that supplies one eye. So if the ophthalmic artery is affected, will you get hemianopia or something else? In PCA we said hemianopia. What will happen with ophthalmic artery? Ophthalmic artery will cause complete blindness of one eye. What is amaurosis fugax? You can get embolus in the ophthalmic artery causing transient monoocular blindness. That is called ipsilateral blindness. why this anterior choroidal cause homonymous hemianopia, that is not supplying the occipital lobe. Hemianopia occurs when there is an occipital lobe lesion. Occipital lobe is supplied by PCA. Then why you should get hemianopia in anterior choroidal artery? Because the anterior choroidal artery supplies the retroleniform portion of the internal capsule. ACA we have said, sometimes you get single congenital ACA. Normally how many ACAs you have? Two. There is a condition called single congenital ACA. What will happen if you get embolus in that ACA? That is called cortical paraplegia. Any other cause for cortical paraplegia? Good. The vein. Artery there is normally two. Vein there is normally only one vein. What is that one vein supplying leg area? Superior sagittal sinus. So if you get a superior sagittal sinus thrombus, it is usually a complication of, I have seen pregnant patients. It is a complication of pregnancy, cortical venous sinus thrombus. They can present with, that is called cortical paraplegia. Then we have MCA stem. If the MCA stem is affected, so MCA three different patterns can come. It can be the MCA stem, it can be the MCA perforatus, and it can be the MCA cortical branch. Then superior division, MCA, inferior division. So MCA then 3-4 manifest. MCA can come in a variety of patterns. So you have to MCA you have to say whether it is MCA stem, whether it is MCA perforatus, or whether it is MCA cortical branch, superior division or inferior division. Posterior circulation also top of the basilar is called cortical blindness. What about basilar artery perforatus, ataxic hemiparesis? What about PCA perforatus? Already all these are things we have already told. This is a repetition only. PCA perforatus is called a pure sensory stroke. Then we have Weber syndrome, lateral pontine syndrome. And there is something called Babinski's hemimedullary syndrome. That means lateral medullary plus medial medullary is called hemimedullary. That means because anterior spinal artery is a branch of the vertebral artery. Pica is also a branch of the vertebral artery. So what will happen if the vertebral artery itself is gone? Then it can get a thrombus of the vertebral artery can cause a hemimedullary syndrome. So finally how to present. So this is the last slide. I think we are on time. How to present a case of stroke. Suppose you imagine that you got a hemiplegia patient in examination. So first you tell the neurological deficit patient is having. What do you mean by neurological? Stroke definition is abrupt onset of a focal neurological deficit. Syncope and he has no deficit means it is not. Some deficit should happen. So first you enumerate the deficits. Examples you can say my patient is having Horner syndrome, he is having right sided ataxia, he is having right facial palsy. You should not say facial palsy, you should say it is right or left, UMN or LM. But either you say my patient is having right LMN facial palsy with left hemiplegia, that is a neurological deficit. So you can say my patient is having global aphasia with the right hemiplegia. He has a right LMN facial palsy with the left hemiplegia. So you mention all the neurological deficits patient is having. Then you say, so list the neurological deficits. Examples for neurological deficits are hemisensory loss, hemiplegia, LMN facial palsy, UMN facial palsy, whatever it is. Or you can say if it is lateral medullary syndrome, list patient neurological deficit. Lateral medullary syndrome has plenty of deficits. Lateral medullary syndrome list you say Horner syndrome on right side, there is a trigeminal on right side, there is a hemisensory loss on the other side, and there is tendinous palsy on one side. So you list all the deficits you picked up. Then you say likely cause, cerebrovascular accident. Examiner immediately asks why you said CVA. I told 3 points. You say sudden onset, risk factors, and obeying vascular territory. Then they will ask you which vascular territory is obeyed. Lateral medullary syndrome, you can say pica, everything can be explained by pica. Aphasia, you can say everything can be explained by medicinal. So you should name one artery and tell that it is because of that artery. So if you are getting hemianopia and aphasia means it is difficult. Hemianopia explain you need PCA. Aphasia explain you need MCA. Two artery example will ask you could it be demyelination, tumors and all they will ask. If it is everything can be explained by a single blood vessel, you name that vascular territory. You say everything can be explained by medial artery. And then you say, so I think stroke. Then what type of stroke? You say hemorrhagic stroke because patient has raised ICT features, he is having severe headache, sudden onset, he was doing activity, he is hypertensive patient. So you have to say whether it is ischemic or hemorrhagic. Early morning suppose early morning stroke, say this more likely to be thrombotic stroke. Underlying atrial fibrillation, mitral stenosis, then you say more likely to be embolic stroke. So that you have to, then sighted lesion. Sighted lesion is that you can say whether it is cortex, internal capsule, brainstem, spinal cord. The brainstem, you can exactly tell whether it is midbrain, pons, medulla. Then you say risk factors. Risk factors means underlying diseases. Then complications. What are complications expected? Most of the patients die due to pneumonia, DVT, hyponatremia, SIAD, so anything bed sore. Sometimes there may be bed sore. So ideally you have to look for the back also. You examine the patient supine position and just turn him back. You will have plenty of bed sore. And that will cause sepsis and that cause death. But clinician is supposed to know that also. You cannot tell that you are neurologist, you won't treat bed sore, let him die of bed sore, I will treat only brain. So that type of, you have to look the patient as a whole. That's why you look for all examination systems. So I think this is the last slide, I think. Thank you.